And so did you and Jody? Okay, well, it is 12:15, so we'll go ahead and get started, knowing that people will be likely coming in maybe with their lunch, and that's just fine. That's why we do it at this hour. I am Tani Hemela with ICSI. I'm the director of the Minnesota Health Collaborative and have had the privilege to work with many fine healthcare leaders across the state and region over the last quite a few years now. And really glad to be here with you today for another part of our series, Mental Health Support for Healthcare During COVID-19. I think we all know the Zoom rules now. On our part, we're always hoping that we remember to send the right links. And for me, that I remember all of those pieces as well. And, you know, before we get started and as we get started, just a moment here to think about our community and what everybody has been going through, both with the pandemic, with George Floyd's murder, and now the Chauvin trial starting. And it's a difficult time for many of us. And this art is something that I have found heartening and a good reminder that even while times are difficult, keeping eyes forward and focusing on what we can do and need to do and keeping hearts open. This has been kind of a personal mantra for me. And so today, it's our pleasure to be able to welcome Dr. Michael Koopmeiners, who's the medical director for Physicians Serving Physicians. They have a unique model, and we're looking forward to hearing about that. Particularly, I think we want to be able to talk today about substance use disorder, and when you see that might be occurring within your workforce, and some of the pieces around that. And so I'll ask Dr. Koopmeiners to go ahead and introduce himself, share a little bit about the organization. And I think, you know, he's welcome to having an open discussion here as we go. So if you have questions along the way, feel free to unmute yourself and ask at any time, or use chat, whatever you're most comfortable with. And with that, I'll turn it over to you, Dr. Koopmeiners. Just one moment here, sorry. There we go.
Okay, everybody can hear me okay? Thumbs up? Okay. Yeah, thanks for having me. I mean, I think these are the slides that I just sort of put together. You know, I'm traveling on the road these days, and so I have a mobile office, and so I'm not as efficient with some of my computer stuff. And the title may be a little bit of a misnomer, but I wanted to just highlight some of the issues that systems, that when we interact with systems, how they've presented themselves, and then actually to encourage you to have more of a discussion about how do we move things upstream, and how do we prevent from getting into this system discussion about, oh, I have this physician, what do I do with this physician? Do I report to the board HPSP? If you're at that point, you've probably missed a lot of opportunities to interact with this physician in a more productive manner. And that's what I'm really hoping to make the case for. Real quickly, just who I am is, you know, I'm retired. I used to work for Health Partners way back when. I retired recently from working 13 years at the VA. At the VA, I was a regional medical director for the Midwest, and I was also a special assistant to the secretary of the VA for systems improvement. I've been working with PSP for close to 30 years now, and Physicians Serving Physicians is a not-for-profit organization, and we've mainly centered on substance use for many years, but now in the last 3 to 5 years, we've really expanded our approach into more of a health and wellness approach. For a couple of reasons. Number one is that I was getting more frustrated with seeing physicians really at the end of an illness episode, quite ill, systems really not responding very well. And I always questioned myself about how can we move upstream. And whenever I looked at a physician's case, there are always opportunities beforehand for intervention. So how do we have those discussions? We have a resource page. You can pull us up on the web, PSP/MN. We have individual help. We have help for physicians and for family members and for trainees. We have systems help. We have intervention, consultation services for physician leaders who are struggling with cases. And then we also have peer support that we've started with several systems now. So just to let you know sort of some of the services that we have. So the next slide, first of all, there's a typo on this slide. This is from 2011. It's a little old. I did pull up several recent studies. I wasn't able to put them in the slides, and I apologize for that. But some of the stuff, basically all of the stuff I'm going to present is still valid based upon a study from West Virginia and from upstate New York, I believe. So, there's a huge cost to disruptive physicians, and you all know this. I don't want to have to spend a lot of time on this. But the big thing is quality of care. IHI has shown that quality of care suffers. And if you take a look at one of the best metrics for IHI for quality of care is what? Is staff satisfaction. What's a negative downer for staff satisfaction? Physicians who are disruptive. Next slide, please. And so if you take a look at, where do the, problems occur? How frequently do you have problems? And again, you probably know this a heck of a lot more than I. But it's not infrequent. And a lot of systems have more problems than 3 to 5 times a year. And I would contend that for systems of 500 to 1,000 physicians or 200 to 500 physician groups, this is probably representing significant underreporting of issues. So this is only what's reported, but I'd be willing to bet it's significantly underreported. Next slide. And so if you look at, do you have a written code of conduct? And, most organizations do these days, but the real problem that, really comes up is how it's enforced, devil's in the detail. And when we've gotten cases, it's almost universal that there are some codes of conduct behaviors that were aberrant for some time that have just sort of been glossed over. And so we'll talk about that. Next slide. All right. So the, I believe physicians' behaviors in my organization are more likely, only reported, and this is the one I really want to emphasize. When physicians are completely out of line, we have a tendency to sort of sweep underneath the rug some of the early warning signs of physicians. And the early warning signs for physicians who are struggling are multiple, and it doesn't have to be physicians struggling with substance use. More and more, we're finding that initial struggles with burnout, with workplace stress, and then all of the struggles at home. How many times do we sort of poo-poo the fact that physicians have home struggles? They have struggles with teenagers, with parents who are elderly, who are sick, and the like. And so, how do we prevent organizations from just sort of glossing over until there's a crisis? And that's when we get called, or HPSP gets called, or legal gets called, or HR gets called. And again, I'm going to make a plug that there's a lot more that can be done ahead of time. Next slide. So, and then, here's the other thing that really dings morale. And whether it's real or not, this is a consistent perception of staff over multiple surveys over multiple times. And that basically, physicians are treated differently. And whether it's right or whether it's wrong, this is a very damning perception of employees in your organizations. Next slide. Right. And then, here's an interesting study is that, you take a look at physicians who are high earners. Um, are they treated differently? 61% say no, they're not. But literally, the close to 40% say that high earners are treated differently. Again, significant problems. We have really challenging cases, quite frankly, from surgeries and from cardiology. It's amazing how sick a system will let a physician become before they want to do something about it. Next slide. So then you sit down and say, what are the substance? What are the root of the problem? And this is from a study from about 6 years ago. But it'll be interesting to take a look at it now and how much burnout is really playing a role. I suspect that substance use issues probably dropping down a little bit, or if substance use issues are there, most of the time right now, we're finding them to be associated with other sort of either mental illness, burnout, some sort of stress, PTSD, or the like. Which is part of the reason that us as an organization really expanded into the other field, because it was really kind of crazy to deal with substance use issues without acknowledging all of the other stuff around that behavior. Next slide, please. So then, the question is, where do the behaviors come from? And literally just 3 weeks ago, from a large healthcare system in Twin Cities that you would have thought would have known better, they called up and they had a big issue with the department. And in talking to them and doing an investigation, they said, well, we've known this has always been a problem. And it's going back 3 to 5 years. So, this is another reason of really intervening sooner as opposed to later. These problems, as well as I, they don't go away. Okay. So what are you waiting for, to really do something about them? Next slide, please. And so, how do you sort of, what are the structure to go about intervening? And, the intervention process, I would encourage you to sort of think about intervention in a much more holistic manner. This is the old classic way of intervention when somebody has significant behaviors that we know we need to address right now. But as I just want to quickly go through this and then we can talk about other issues. But, this is sort of the classic way of going about doing it. And, how does this apply maybe to behaviors that aren't so severe? And what would happen is if you did this the first time a physician did something that you said, this is really out of character for this physician, what's going on? But first of all, when we get called in, the first thing we do is we take a look at the behavior, we do an investigation, talk to people. We take a look at, clearly documenting the behavior. This is all old HR, human resources stuff. This is human resource 101. And the hard part of this for systems is number one is to define the goal of the intervention. I can't tell you how many times people have called up and said, we just want to get rid of the person. I says, well, you just want to get rid of the person, you don't need me. If you want to try to, help the person get healthy and become a productive member of your association, then I'm happy to get involved. But if you want to just get rid of them, you don't need me. You need lawyers. You need to define the consequences of the behavior. You need to be blunt in this. You can't couch this and, well, maybe this, that. You really need to be very definitive, declarative statements. And then you talk about, who, what, when, where, how. Next slide, please. And then, there you go. When you do an investigation, the question is, and this is where I think a lot of systems struggle with. You sit down there and say, well, is this behavior we need to report to HPSP? Is this behavior we need to report to the board? HPSP's position is, we're really a monitoring agency for the board. they don't do investigations. They take a look at the health and wellness of a person. Do they have a medical condition that needs to be treated? And if left untreated, would impair their practice of medicine. And so, for instance, I had an organization called up and they said they referred this person's to the HBSB. HBSB said they didn't have a chemical dependency or depression. And so they didn't have any monitoring, so they could go back to practice. And the medical director called up and says, but the guy's still being a jerk. And I said, well, you asked a perfectly good question of HBSB, but you didn't ask a perfectly good question for your organization, which is what's the genesis of this behavior? And what does an organization need to do about the behavior? And so one of the things that PSP can offer, or other organizations, is really to take a more holistic behavior approach of saying, what are the stressors involved here? And what needs to happen to help this person get better? Because even if they don't have something that needs to be monitored, they still have something that's causing disruption to the system. And so the other thing is to look at how good is your data. Um, you know, the data, depending upon the severity of the behavior and the severity of what we think the person might be struggling with, I will sort of fudge on how strong I want the data. If I'm really concerned, I've intervened with sort of sketchy data um, simply because the behavior was just so aberrant. The less aberrant, the more sort of iffy, I think the better off you can do with getting data. But you also generally have time to do that. Okay, next slide, please. So, and then, here's the typical goals of the intervention. And the areas that systems struggle with generally here is consequences with or without change. The intervention is just as much an intervention for the system as it is for the individual. The system has been willing to tolerate the behavior for a while, generally, not always, but generally. So the question is what's changed? And why is the system all of a sudden now getting concerned? And what is the system willing to do different? If the system isn't willing to do anything different, well, then don't bother. And this is a wonderful story where when I worked for Health Partners, Mary Brainerd called me up and said, Mike, can you go to this clinic and help them work through an issue? They were going to lose a major client. And I says, okay, that's fine. And I went to the leader and I said, I'll come out, I'll help you, but you need to set the stage that there is a significant problem that needs to be fixed. So I went out and the physician sort of waffled and said, well, maybe we have a problem, maybe we don't, but Dr. Koopmeiners is here to help us out. And I ended the meeting and I took the physician out and I said, if you don't think there's a problem, why should your staff think there's a problem? And how am I going to overcome the fact that people just don't think there's a big issue here? So number one, the system has to agree there's an issue, but the system has to also then agree that they will follow through on consequences that typically are negotiated during the intervention. So if the system isn't willing to do that, then the system is more of a problem than the person probably. Next slide, please. And so, here are the consequences. And, when you're at this point, you're pretty far down the line. And so what I would encourage you to do is take a look at what are the behaviors that you would generally think are problematic, but would not make you think of doing any of these steps. Those are the behaviors that I would encourage you to focus on. The behaviors where all of a sudden the person isn't showing up on time, maybe misses is 20 minutes late for surgery, not a big deal. But this is a person who's always been on time. This is a person who all of a sudden struggles with their medical records. If you take a look at physicians who are in active recovery back into practice, one of the best predictors of a relapse is actually medical records completion rates. medical record completion rates will start to drop off long before they get into active relapse. So again, I want to emphasize, if these are the things you're thinking about, the person is pretty far along their course of illness or struggles. What are the behaviors that would not make you think of doing any of these things that would make you concerned? And how do we start interacting with those behaviors long before we get to these? Next slide, please. Okay, and then, you need to define the system's responsibility. What support will you be make available? And what system change may be appropriate? One of the struggles that we have from an organization, PSP, is to go in and interact with the person, and the person will always bring up the system, almost invariably. And the problem is that the system always has some contributing factors. They may not be a lot, but the point is that it's important to acknowledge that most of the time systems are capable of doing some change, and what support will be made available. For instance, we have physicians who are burnout, and these days it may be very difficult, but there are some physicians who sit down and say, with their mental health providers, it's just not healthy for you to continue to be working, 50, 55 hours a week. How do we cut down on their time in clinic? Very, very difficult, very difficult. Simply because everybody else is likewise stressed. So how do you support this? And I can tell you one case that the person who is most disruptive, in a well-meaning way, but most disruptive to the physician's recovery was actually the front desk clerk. Front desk clerk says, this person wants to see you, you've always seen them, so I just put them on your schedule. And you sit down and say, no, you can't do that. So keep in mind is that we can help with physicians, but I'm going to almost always challenge the system to say, what are the things that you need to look at? So next slide. And then, who will be present? And again, if you're thinking about this, or if you're thinking about bringing in HR or thinking about bringing in lawyers, you're probably too far down the stream. What would be the things that you could do with, typical HR stuff? What are the non, just counseling episodes? How about doing something as simple as, I'm just concerned. You don't look like you're enjoying your practice of medicine as much as you are. I can't tell you how far some of those little things go, but we're afraid to do them in general, which I just don't quite understand. I know the logic and the study, what the studies say, but what would happen if we just got to the point of saying, how are you doing? What would happen if we had a morning check-in and everybody went around and say, okay, on a scale of 1 to 10, what's your emotional health today? How would that change the practice of medicine and prevent you from having to deal with these issues? Next slide, please. And then when, where, how, usually when we get called, it's usually more urgent. I always sort of struggle with that, but these are the things that we need to take a look at. So next slide. And then the return to work issues, I think I've addressed those a little bit. I tell you, one of the techniques that we have available with PSP is we can deal and concentrate on the health and wellness of the individual. HPSP has a dual reporting structure. They have to worry about practice of medicine and the individual. Again, both of us are worried about the same thing. It is just the emphasis. With PSP, let's say somebody calls up and say, I'm really using too much alcohol and I'm going to work hungover. I'm going to sit down there and take a history, do an evaluation. And then if I really think that they need to go further, one of the things I'm going to do is say, how about if you take a sick leave? I'm not going to go to HPSP first. I'm going to say, let's concentrate on yourself. Take a sick leave, get an evaluation at a CD program, and follow through with the evaluation. So once I can be aware that they're going to be out of the practice of medicine. They don't risk patient safety. All of a sudden, there's this opportunity to help them focus on themselves without this hanging over their heads about practice, license, all this other stuff. Well, after they're, and now we need to do a monitoring program. HPSP is involved if they refuse to do anything different. So again, PSP has the ability of interacting sooner with a little bit softer hand, but with an outcome of still keeping patients safe, because patient safety is also good for the individual's health. So again, it's just a matter of interventions and timing. So next slide, please.
And I will mention you're breaking up just a little
And
bit
so
there.
I think that's
Oh,
the, yeah, and then ongoing.
can you hear me?
Okay, is this better?
Now
can hear
it
you.
is, but maybe it's time to switch to your phone audio.
Okay. Put it this way.
Thanks, Al. He had it set up just in case this might happen. So, oh, he'll be on with us shortly. So in the meantime, do think of your questions to ask along the way too.
Okay,
We're getting twice.
okay, I'm back. Okay.
Sorry, folks.
I'm going to leave that. Okay, I'm back. So, are you able to hear me okay?
Yes, now it's good.
Okay, so anyway, I apologize. But I open it up for questions. But the ongoing monitoring, is really very important. And we've helped with that. HPSP now. I mean, I help write the statute for HPSP. They do a very nice job. We have the ability to monitor after HPSP stops. Some organizations have wanted us to continue to monitor for physicians longer, and we've done that. We've sometimes monitored physicians even if HPSP has decided not to, for whatever reasons. So that's those are some of the services that we provide too. So with that, I think that's the last slide, and I just leave it open for questions and comments, and what questions do people have, and how can we help?
Well, I'll jump in with a question that I was wondering about. Thank you for the information and the presentation. One of the things that I was struck by, you were talking about how to move upstream, how to help physicians, help people earlier upstream before it gets to be that really urgent crisis. And you mentioned noticing that completing medical records, seeing that drop off is one indicator. Are there other things that people should be watching for?
Number one is just something soft mood, and how can we, if somebody's struggling, how can we just ask how you doing and listen? Some of the old commercials, TV commercials, PSA about mental illness and depression. How do you just ask the question and stop and listen? Patient satisfaction scores, they're a little delayed, although some systems now have immediate patient satisfaction scores available. You'll start seeing those drop off. The best indicator, actually, from several IHI studies and a Virginia Mason study, is actually staff satisfaction. You'll see staff satisfaction drop off. So those are some. Family members, they're always hard to engage in workplace. family members can also be very telling. They have a tendency to struggle with the same thing healthcare systems do, which is that what happens if I say something and the physician loses their license? You know, if you have to worry about if you say something, the physician losing your license, you probably need to say something because the physician may very well lose their license if you don't. And so how do we make it okay to at least approach the issues? Those are some of the ones. There are a lot of soft findings. When we monitor physicians, one of the things that we've done, harder to do these days, but we've actually just sent a 3-question survey to staff once a week for people who let them agree to do that. Very predictive of how the physician is doing, and very general questions. You know, how do you think the physician is doing? Rate them on a scale of 1 to 5. And so it's mainly those are the sorts of things that we look at.
So one of the things that I'm hearing you underneath what you're saying is creating that environment to a psychological safety or spaces where that can happen. I know a number of you earlier on in this series who have attended have spoken about that in your own organizations, particularly now during this time of increased stress. Physician burnout, physician suicide has been high before the pandemic. And I know a number of you and your organizations have been working on ways to try to address that. Does anybody want to speak to what you've been doing and how that might kind of things that might be effective? Here's a question from Lisa in the chat. Do you have good examples of preventative campaigns, action that organizations can take that try to target physicians from a universal perspective versus individuals that get identified as struggling? Good question.
Well, one of the things is that if you go on our website, and I don't get paid for what I do, so this is not a commercial break. This is all funded through donations. If you go on our website, we actually worked with a marketing firm with how to get out messages to destigmatize asking for help in mental illness. And so, and there have been 3 or 4 organizations now that have used, we have little flyers about it's, it's okay to talk about it. It's, have a seat, we're here to listen. All of the things that we as physicians generally do to patients, but we don't think about doing to ourselves. So what we did is we turned the mirror on and said, these are good for you just as well for the patients. So, there's some marketing tools that you could certainly use. The other thing that has been successful is to, all due respect to all of the administrators on this line, take administration out of the picture. What we've done is with peer support. This is based out of work done in Upper Peninsula of Michigan, in that literally promoting peer support to peer support, and having a total separate silo of support for physicians that really doesn't even go up the general channels through an organization. So, for instance, with the peer support. Let's say somebody has a bad outcome at ER or OB, they have a death. They can either ask for help, or quite frankly, one of the peers could actually go into the app. It's an app-based protocol. Go into the app and say, somebody should call this person just to check in and see how they're doing. And so all of a sudden, the person will get a phone call, said, hey, I hear you had sort of a struggle in OB. How are you doing? And so that's another example that we're just starting. We're really quite hopeful that that will get upstream on that. As far as cultural change, you probably know all that better than me, is that, that's a 3 to 4 year stint or at least. And it's a real struggle. It's a real struggle. And look at the military. See how the military did it. Military, has your six. Very effective campaign for all you people in the military. There was another question.
Here's one. How do you help staff provide feedback to toxic physicians that they frequently don't know how to do that?
Well, the hard part is to get the physicians to be open to feedback. And, that's gone all the way from several sessions of individual therapy with the physicians. And that's available free through our services. Physicians can call up, family members can call up. And then, sometimes for staff that are particularly strong, they can provide it. But quite frankly, just simply because of the power differential, that can be a real disaster sometimes. So, we've right now we're working with large organizations, and we're actually facilitating group sessions where we will bring in a counselor on our dime, and actually worked with the individuals, worked with the staff, and now we're just starting to bring them together to start having engagements. And then, quite frankly, I've gone so far as to say, firing is an option. And I think we always have to consider that. But those are the ways to do that. And, if we can empower the staff, great. We have to empower it in a safe way. But if they're that afraid, generally bring in some outside resources to sort of help them work through. And then if the system has to be willing to give them the time to do that. How helpful do you think it might be I didn't see the full question.
Yes, to have universal education to physicians on burnout, depression, suicide, substance use, etc. Will the right people listen?
Oh, I'm so glad you brought up that question. One of the things that we started to do 3 years ago is actually with new residents, having them be required during orientation to actually spend time with a counselor. And the first session is to actually spend time with the counselor saying, these are the services available, and sort of try to assess and help them self-assess their emotional IQ. And how aware are they of their emotional responses and the like. We've taken that and said, okay, now we're going to expand that so they get 3 sessions over the year of their first year, free sessions on the system's dime to sit down and say, okay, this was the orientation. How you doing at 3 months? How you doing at 9 months? To normalize the fact that these are the resources available and we can help you out. I would absolutely love to try to entice a large healthcare system to sit down and say, what would happen if every new physician in the organization was required to meet with a counselor during orientation and a counselor every quarter over the first year? You sit down and say, oh my God, that's a huge cost, Coop. Well, you're looking at 4 hours of a physician's time, depending upon the physician. You could be taking a look at what, $200 to $500 an hour. Okay. We know that if you help with burnout, you're going to reduce turnover. So ask yourself, how much will it cost you to do this? And how much turnover do you have to prevent in order to make it cost effective? And some of the early studies, you could argue about the numbers, but if you're taking a look at preventing 1 turnover in 5 or 7 years, you've paid for that system. So anyway, the findings are soft, but one of the things I learned from Mary Brainerd was, if you want to do cost analysis, only account for hard dollar cost, not soft dollar cost. And so that stays with me till today. Those are hard dollar cost savings for you. So yeah, I think that's one of the things that I would love to see more people do it. How do you get the attention of people, of the right people? Well, when I talk to CFOs, I talk about the dollar cost, but every time I talked about the dollar cost, I'm actually talking about individuals. So when I talk to CMOs and CEOs, I talk about how well do you want to have a corporate culture of health and wellness? Because the better health and wellness culture you have, the better healthcare you're going to deliver. Those are the pitches that I make. I a little evangelical about that, but if anybody wants to work on that issue, I'd love to participate and try to make the case.
We have time for one more question. If anyone has them, go ahead and unmute or send it in the chat.
This is John Alvin from Sanford, and I just wanted to. I really like the comment about. I think that's a great idea about new hires and finding a way to have them meet one-on-one with someone. I think that's a great idea. I wanted to add two things. That what we've done is we have developed a 2.5-hour session for all of our for everyone who goes through our new provider orientation that is focused on well-being and preventing burnout. And we rotate that through with the people who do some of our individual services with our clinicians, and it's just been nicely received. And what we found is that those folks have been much more willing to reach out for the individual services as time's gone on. So I just thought I'd plant that seed. And then the other thing that I've been doing for the last couple of years is doing a resilience or well-being support group for our residents that we have with one of our residency programs. And again, that's just something else that's so on a monthly basis, we're checking in with the residents on how they're coping with their program, and also finding that really opens the door for these folks to reach out for individual help if they need it later.
Yeah, thanks for bringing that up. You know, we do something similar. Is that, you know, before they do the individual sessions, we're always part of their general orientation. So we have varying lengths, an hour to 2 hours. And so, you know, we do that. You know, the other thing that we've been doing is actually then physicians who have critical incidents, we also then make them available of saying, okay, here, and have them opt out of the appointment as opposed to opt into the appointment. But yeah, those are great ideas, and you know, I agree with them wholly.
Well, thank you for the questions all, and thank you, Dr. Koopmeiners, for the presentation and discussion. I'm going to just share, take 60 seconds or less to tell you what's coming up. Thank you, Mickey. And thank you all. So we have on, the date will be defined here in the next couple of days, but some specific actions that a few healthcare systems are doing to support their staff, both during and after the Chauvin trial. And also April 7th, we've got the beginning of a panel discussion, and we need other panelists. So if anyone has an update on what you've been doing that you found out is really supportive and helpful for your workforce, or other things that aren't quite so much, we'd love to have you join the panel, and you'll hear from us as well. So that's all for today. Thank you very much.
Thanks for having me. And if I can ever be of any help, you know, you have our email contact information. You can contact me directly, but happy to help, and I appreciate the time.
Excellent. And I'll send out the information that Amber said she'd send to groups that she has. So I'll send that out to all of you. She contacted me.
Perfect.
Thanks, Amber. Thank you. Bye.
Thanks. Bye. Oh, hi, Claire. Nice to see you.